This week on the BackTable podcast.
I would encourage your guests to start as a default. Every single thing that I do, every service that I perform can have a price attached. From there, I would start talking to the buyers. Look at the Free Market Medical Association. Consider joining so that you can network with self-funded buyers from all over the country who will waive the deductible and copay and pay all the travel costs for their employees to come see you. Assume you can do this. Acknowledge that the hardest thing about creating bundles and placing prices on our service is keeping it simple. And don't let it get overcomplicated.
Welcome to the BackTable podcast, your source for all things interventional and endovascular. You can find all previous episodes of our podcast on iTunes, Spotify, and on BackTable.com. Now, a quick word from our sponsor.
This episode is supported by Reflow Medical, makers of high-performance medical devices for peripheral and coronary interventions. Reflow's approach to finding solutions to unmet clinical needs is known as the innovation algorithm, where physicians work with Reflow in a continuous loop throughout development. Successes include the Wingman catheter for rapid CTO crossing, the SPECS LP, low-profile support catheter for improved vascular access and crossing, and Cora catheters, a suite of tools for use in complex PCI procedures. The innovation algorithm, products that are physician-imagined, Reflow-engineered. For more information, visit reflowmedical.com. And now, back to the show.
Hello, everyone, and welcome to the BackTable podcast. I'm your host, Dr. Ali Behetti. I'm coming to you from Tacoma, Washington. My guest today is Dr. Keith Smith. He's an anesthesiologist and the founder of Surgery Center of Oklahoma and co-founder of Free Market Medical Association. Keith, thank you for coming on the show.
Thanks for having me.
Today, we're going to discuss alternative practice models within the ASC. So first, I'd love if you could give us an introduction to the Surgery Center of Oklahoma.
Surgery Center of Oklahoma was co-founded by myself and Dr. Steve Lontier, another anesthesiologist who was like-minded, and came to the conclusion in the early 1990s that physicians were increasingly underpaid for what they did, and that hospitals and hospital administrators were grossly overpaid. At the same time, we came to the conclusion that the hospitals as financial institutions were instruments of bankruptcy for many of the patients that entered the doors in spite of their so-called not-for-profit label, which does not mean that they're missional at all. Not-for-profit just means don't pay tax. And so at some point in the mid-90s, Dr. Lontier and I felt like accessories to a crime. We were anesthetizing patients for routine operations like carpal tunnel release, tonsillectomy, and hospitals were bankrupting these patients. I felt like an accomplice. And I knew as an anesthesiologist, there was nothing I was ever going to do to intervene in any way or to protect patients from the predator hospitals unless I owned and controlled my own facility.
Now, a quick question for you. Just the 90s were a little while ago, and I know now there is a really big price discrepancy kind of based on site of service for hospital outpatient, inpatient, ambulatory surgery centers, and OBLs. Was it a similar situation in the 90s?
No, the problem in the 90s was that's when the government, through Medicare, became extremely heavy-handed, victimizing primarily hospital-based physicians, radiologists, anesthesiologists, pathologists, and ER docs. That's when they launched the Resource-Based Relative Value Scale, RVRVS, where they attached a fee to every service that we provide, and they got them all wrong. The ones that were too low created shortages of those services, and the ones that were too high created surpluses. And so there were a lot of services and procedures that were performed that should not have been because they were overpaid. A lot of services, like my services, which disappeared. I fellowship trained in cardiac and pediatric anesthesia, and I stopped doing cardiac anesthesia because the last time they paid me for a heart, Medicare sent me $285 for the anesthetic. So wow. it was time to respond to these price signals with a rational signal of my own. So Price controls cause shortages, and I just made myself short. I just quit. And I didn't quit seeing Medicare patients. I just quit filing claims. So in the early 90s, when this was going on, they were underpaying doctors for the most part, particularly hospital-based physicians, but they started paying hospitals a lot more. And simultaneously, the hospitals became financially very aggressive with patients, all the while telling the surgeons that I worked with that they couldn't afford to buy the supplies they needed to appropriately perform the surgery. So it was just time to walk away, and that's what Steve Lautier and I did in 1997.
So how long was it between time of conception of the idea to you opening your doors?
It was about 5 years. I tried and failed, I don't know how many times in a 5-year period, probably 15 times. It was very frustrating. And then Steve and I found ourselves on a hunting trip with some guys who were in control of a facility we'd had our eye on that was failing. And we basically bought an existing facility that was financially in trouble on a hunting trip.
Wow.
We did.
How about that? So tell me a little bit more about the ramp up of your facility and how you were able to engage doctors to work there.
When Steve Lautier and I were in practice, we had a loyal following of surgeons who loved the service that we provided, not just to their patients, but also to them. We're very efficiency-minded, very high-quality focused for the patients. So when we walked out, these loyal surgeons went with us. It was our quality reputation that really launched the Surgery Center of Oklahoma. And we launched in May of 1997, and we did it with an idea that we would never accept money from the government and that we would always make sure patients knew what they were going to need to pay us before they arrived. So there would be no financial gotcha. There would be no bill that arrived that was a total surprise to a patient. We started quoting prices over the phone the first week that we were open. Patients would call and ask, how much is this procedure or that procedure? And I had no idea how radical it was at the time to just call the surgeon and ask them, how much do you want? Do some kind of a time and materials analysis for the facility, put a price as an anesthesiologist on my time, and add them all up and give the patient an answer. At the time, I had no idea how radical that was, but we quoted prices over the phone the first week we were open.
That's amazing. I mean, yeah, when you think about it that way, it's just adding up all the sum of the parts, right? And then giving an answer. But yeah, it must have been a totally radical idea at the time. Did you ever contract with any insurance companies for this center, or was that never part of the game?
The insurance companies hated us. We didn't understand that at the time. We started with a high-quality reputation. The surgeons that we worked with, Steve Lautier and I would not grant privileges to surgeons that we would not let operate on us. That was our rule. And Steve and I were known in the community as, very high quality, very competent at what we did. And so the facility grew pretty slowly at first. I would say the first 6 to 9 months. And then it exploded. And the next thing we knew, all the Division I athletes in the state of Oklahoma were having their surgery at our facility outside of University of Tulsa. Even professional athletes, golfers, basketball players, football players would come primarily because of the surgical talent that was there. And so this ramp up, it happened, it was a little bit slow the first 6 or 9 months, and then it just took off, and we outgrew this small facility that we occupied initially. We outgrew that in about 3 years. We managed to stay there for 6 years until 2003, and then we built the facility, a very large facility that we occupy now. There were 12 surgeons on staff when we started, and I have 157 surgeons on staff now.
That's quite amazing growth over that span of time. So what are some of the challenges that you faced while you were ramping up the facility in the early stages?
Government, mainly. The state government, like I said, you asked, were we a network with any insurance carriers? And we were not. We did not understand it at the time, but the carriers did not want to work with us. We had a we had a reputation pretty fast that was high quality, reasonable pricing, and the insurance carriers wanted nothing to do with value. That was real clear, but we didn't understand why. And it only became clear later when I posted the prices on a website. But the primary challenges that we had were all downstream of government goons, is what I call them, at the state level and at the federal level. We had real issues with legislators who attacked us, paid by hospital and insurance lobbies. Once, they kind of ignored us when we first opened, and then they began to attack us pretty viciously. So I spent an embarrassing amount of time at the state capitol in Oklahoma defending our right to operate this practice. And the really funny thing about it is every single thing they tried backfired. Every single thing they did.
What do you mean?
Well, so we didn't accept government money. So whenever I went to the Capitol, the legislators found me to be pretty refreshing because I didn't want anything. I just wanted to be left alone. And all the hospitals and insurance carriers, they had their hand out. They wanted to plug into the taxpayer trough and suck it dry. And when I would show up, I would say, man, I just want you to leave me alone. Let the market work. We will do everything we can to make sure quality is high as it can be and prices are low, and we'll provide value. And sure enough, we developed this reputation as an underdog, as a champion of the poor. And so when these so-called not-for-profit hospitals that were charging 10 times what we did for the same service, when they accused us of being greedy or something like that, or they attacked us at the legislature, it backfired. It didn't do them any favors. It just made us busier. They finally stumbled in 2006 on something that hurt us. They stacked deductibles. So up to that point, we could file an out-of-network claim, but have the patient pay us an amount that was less than their in-network deductible, and that was their in-network deductible was more than our all-inclusive fee. So
wow.
we would file an out-of-network claim, and the patient would have no more out-of-pocket. Well, what happened was the insurance commissioner in Oklahoma allowed the insurance companies to stack in and out-of-network deductibles on top of each other. And what that meant was no patient that came to Surgery Center of Oklahoma had any out-of-network benefit until they had already met their in-network deductible. And so that put us out of financial reach for a lot of patients and just about closed our doors. And that was in 2006, 3 years after we had opened this brand new, beautiful, huge facility. It was devastating. And my response to that was just to put all of our prices online.
Wow. All right. So how did the hospitals react to that? You putting all the prices online?
Well, it's like the old Gandhi quote. At first they ignored it, and then they laughed at us, and then they fought us, and then they lost. We won. I mean, it was really an interesting progression. But when I launched the website in 2009, the first patients to arrive were Canadians. Mm-hmm. And we thought that was pretty interesting, because, these people supposedly have insurance. They just don't have access to the care that many of them require. So
sure.
The most common story was a Canadian lady who needed a hysterectomy, and she was in a line that was 3 years long and was tired of getting transfusions. And so for $8,000, she could fly to Oklahoma City and end her nightmare. All in, $8,000 for a laparoscopic-assisted vaginal hysterectomy for surgeon anesthesia, facility, pathology, all of it. And so Canadians started showing up, and then uninsured people all over the state of Oklahoma and outside of the state of Oklahoma started coming. And then I connected with the self-funded companies, the self-funded industry, these companies that decide to pay for their employees' health needs out of operational revenue rather than buy risk from Blue Cross, United, Cigna, Aetna, Humana, something like that.
I want to talk about that a little bit more too, because that's something I think a lot of people want to learn more about. Do you have any numbers about how many employers across the country choose to do that for their employees?
If you think about the number of dollars that are spent on medical claims in the United States, half of the dollars are spent by government entities, whether it's Medicare, Medicaid, Indian Health, TRICARE. Then there's the other 50% of the money. Of that 50% of the other side, 80% of that is from self-funded companies.
Wow, I didn't realize it was that high. Okay.
About 80%, and a big part of the rest is from cost-sharing ministries, the size of which are growing. All of them are growing. But the self-funded buyer is typically a company that has 50 or more employees. The Unaffordable Care Act made it much easier to justify self-funding. We saw, companies that, had 500 employees would self-fund, but no one under that number. Well, now you see companies that have 30 employees or 25 employees, and they're making the decision to bear some of that risk themselves. Now, I made the decision in the year 2000 to self-fund. I asked an insurance friend, I'm paying Blue Cross $20,000 a month. I know I'm going to spend $240,000 a year on, benefits or insurance for my employees. Why can't I just buy a policy that's got a $100,000 deductible, take that risk, and if their expenses are not that high, I win. If their expenses are higher, I lose, but I'll take that risk. And he said, that's self-funding. And he said, you actually don't even have to take that much risk. So we've saved millions of dollars by self-funding, and it's become very popular.
I bet it'll just grow kind of as premiums increase and people's deductibles keep going up. But yeah, that's definitely something a lot of people are very interested in. Is that at all related to the Free Market Medical Association?
Yes. So not long after I launched the website in 2009, I met Jay Kempton. And Jay Kempton owns a third-party administrator, and he's called the Kempton Group. And the way that works is, let's say you are the CEO of a company that has 1,000 employees, and you want to self-fund, but you don't know the first thing about how to accept and process claims from hospitals, anesthesiologists, and the rest. So you hire someone like Jay Kempton, and you throw them your checkbook, and you say, tell me how much we need to keep in our insurance fund, and you pay the bills. And so these third-party administrators, they basically hold the checkbook for self-funded companies, and they pay their claims. And they also kind of look at the bottom line, and they make sure that, the price gougers out there know they're dealing with someone who knows that a carpal tunnel should not be $30,000. So
right.
As a self-funded buyer, you basically have the same sticker shock that an individual does who's buying their care. So when the self-funded world met me, they got real excited because they realized they could buy a carpal tunnel for $2,950 and not have to worry about spending $30,000 at one of the big hospitals. So the hospitals began losing business to me primarily because the self-funded buyers put their foot down and did everything they could to steer their employees away from the price gougers and toward people like me. So the Free Market Medical Association was Jay Kempton's idea, and it was formed to put buyers and sellers together, really in the same room, without all of the suits, without all of the intermediaries that do not want buyers and sellers to speak directly. So if I'm talking to a self-funded buyer and I say, we will do a laparoscopic cholecystectomy for $6,836 all in, they know that they've been paying $42,000 for that, and they get real excited and say, why would you do it for that? And I said, well, because I want your business, and I want your business long term. The Free Market Medical Association is that tool and that association that allows those relationships to flower and to happen. It's grown. It's huge now. I think there's 34 state chapters. It's just become a very, very cool space for people to meet. We just had our annual conference in Oklahoma City, and there were like 550 paid attendees, and it was very, very exciting. We've had Steve Forbes and Ron Paul and Kennedy from Fox. We've had a bunch of cool keynote speakers. It's a very, very cool conference.
In that scenario of a direct relationship between an employer and your facility, should there be a need for hospitalization after a surgery or a procedure, who's on the hook for that hospitalization? And I guess the corollary question is, do all of your surgeons have hospital privileges at a nearby hospital?
Well, the answer to the second question is yes. The answer to the first question, what do you do when something goes wrong? Well, you hope that something goes wrong so infrequently that it makes sense for that employer to take risk. Now, if an employer is self-funded, they have a kind of it's called a stop-loss policy. It's kind of a safety net. If everything goes wrong, Lloyd's of London kind of policy that it is a backstop to protect the employer and that health plan from bankruptcy in case something terrible goes wrong. So it mitigates the risk, though, for an employer to decide to patronize a facility like mine, because the people who sell those stop-loss policies know that they are not nearly at risk like they would be if the patient went to the hospital to get a carpal tunnel release, which is going to be wildly expensive. The chances of infection go way up. What if something goes wrong is covered by the stop-loss insurance in terms of how you look at it through the self-funded company's lens.
Got it. Since 2021, there's been this Price Transparency Act, right? So theoretically, hospitals are required to post their prices online just the way you do. Theoretically, consumers should be able to do an apples to apples comparison of prices. Would you care to speak a little bit about what you've seen in terms of hospitals doing this and if it's caused any consternation within your group?
Government never gets anything right. And I never worry about anything really until I hear that the government is showing up to try to help. So this price transparency movement really has nothing to fear except the government's assistance. When the federal government decided to mandate what the market was already commanding, and that is price transparency, the price transparency movement took a real blow. I predicted one of the unintended consequences of governments mandating price transparency, and Jay Kempton predicted the other one. My prediction, which has come true, is that the government would sell indulgences, that the government would mandate price transparency and then sell exemptions to the big boys. And that's exactly what's happened. So they have these fines for non-compliance, which only the big hospitals can afford. So the little hospitals, who are still wrapping their minds around how do we do this, are being consolidated and they're being purchased and taken over by the big boys. But that was the whole intent of mandating this. I mean, the American Hospital Association, they saw that as a huge opportunity to further consolidate ownership of hospitals in the United States. Keep in mind, a part of the Unaffordable Care Act that most people are not aware of is the support of the American Hospital Association was achieved only when the Obama administration guaranteed them and put into law that physician ownership of hospitals would no longer be allowed, and those hospitals that were owned by physicians could not expand. So, they do everything they can to thwart competition. Jay Kempton predicted the other consequence, and that was that price transparency would be redefined. We know now that in the Trump White House, price transparency became redefined as what is the patient's out-of-pocket, not what is the cost of this service delivered, but what is the patient's out-of-pocket. So it's been watered down.
That's a good point.
Favors are being sold. Thank you, government, but no thank you, government. Just please stay out of this and let the market do what it's supposed to do.
I wish the market would just do what it's supposed to do. But like you said, I mean, people they'll have a emergency or they'll have to have a surgery. They'll get a bill like 6 months later for whatever it was. They'll be floored by the price. They, might have to default. They might have to go into bankruptcy, and the hospitals just come after them. Unless there's price transparency up front, I don't know that people can really make knowledgeable decisions for themselves. And you spoke to something very, very powerful. I think that it feels as doctors like we're complicit in all of this because we're just a widget to a lot of these hospitals, right?
Yeah, and the market is working. I know for a fact that the price sheet of Surgery Center of Oklahoma has been displayed in the courtroom whenever a hospital has been taken to court for price gouging.
Wow.
And these not-for-profit hospital administrators are on the stand under oath, and they're being asked pretty aggressively, how do you charge $30,000 when this surgery center, this greedy bunch of capitalist pig doctors, are charging $3,000 for the same thing? How do you justify that? And how do you justify bankrupting my client because you didn't receive, the $27,000 that you say you're due? With the pricing becoming more and more available, there's a lot of accountability presented to the hospitals now that is very creepy for them. So I think we're better off to just give it time and let it develop and grab our wallets. And when the government rides in on the horse to help, that's very scary stuff.
Have you ever considered expanding outside of Oklahoma?
Well, not until recently. There's a new group that I am working with. It's called Smith Medical Holdings. They honored me by naming it after me, but they plan to open 10 surgery centers in different parts of the United States that copy the Surgery Center of Oklahoma model. And the first one, Surgery Center Denver, just opened in Littleton, Colorado. So Smith Medical Holdings is a very exciting development. There are copycats all over the United States now that have copied me. There are also facilities that I've helped that will quote prices over the phone. Now, they don't have a website where they're posting them, but if you call and ask, they'll give you an answer. So that's kind of a hybrid approach. Some people are very scared of the carriers because they do have carrier contracts. I'm unhinged. I don't have carrier contracts, and I don't accept money from Medicare. So I just say all the things all the other doctors are thinking and wish they could say, but they're basically sandbagged. So this movement is growing. It's really hard to tell how big it is because even hospitals, I know for a fact, when patients call and say, I'm going to fly to Oklahoma City and have my surgery because the hospital wants $40,000. And they say, well, wait, why are you going to Oklahoma City? Well, because it's $4,000 there. Well, why don't you just stay here in town and we'll do it for $4,000?
Oh, yeah. They'll price match.
Yeah. So there's price matching going on. And so it's really hard to gauge how widespread this has become. But that is how the market works. That is the beauty and the power of the market. When some greedy price gouging hospital, cuts $36,000 off some bill because they're afraid of losing the business. This is America, for God's sake. Every other industry works that way. And so I'm always excited to hear those stories. We had a guy from Georgia call me and told me basically that a hospital price matched me at $4,000 and their starting price was $40,000. And he said, you realize you saved me $36,000 and you didn't even do the surgery. So that's pretty cool.
That is pretty cool. Yeah. I like you, Keith, because you say the quiet parts out loud. It's a talent. Are there any surgical subspecialties that you think would not do well in this model?
I think that traditionally surgical subspecialties that belong in an academic center or a very large team approach, it's still possible, but it's harder. And it's harder because there are so many components to assemble in order to curate a bundled episode of care. It's not impossible, but it is hard. For instance, pediatric cardiac surgery, that would be hard. Pediatric neurosurgery, that would be hard. It's not undoable. It's just that the market is going to have to send a signal into the industry that says, we want price transparency for tetralogy of Fallot. We want price transparency for however many DP shunts and revisions this child is going to need. And then somebody's going to sharpen their pencil and get in there and compete. But right now, the market is not really sending that signal. Keep in mind, there's a reason that we have the whole concept of insurance. Insurance is about uncertainty. And so some of these very super specialized fields are more suited to payments from third parties like insurance companies. But you should not be using insurance to buy your colonoscopy. You can buy that for $1,100 all in here in Oklahoma City. I'm not even sure you should use your insurance to pay for uncomplicated major surgery. You can buy open heart surgery, a 3-vessel bypass in Oklahoma City for $34,000. Now, $34,000 sounds like a lot of money, but if you're paying $1,500 a month to Blue Cross, that's just 2 years premiums. So, yeah, I mean, some things I think are more suited to insurance. It's those, but insurance is for very rare, very expensive, very rare events. It's not for office visits. It's not for physical therapy. It's not for closed reduction of a forearm fracture. That's silly for insurance to be involved in a primary care doctor's office. That's just insane. So that's how I look at it.
Have you looked at expanding outside of surgical fields, like direct primary care models and things like that?
Yeah, I pretty much am staying in my lane with surgical bundles. And when I say bundle, that means the price for an episode of care. Just cash out the door. And I've expanded outside of outpatient procedures to curate inpatient surgical bundles. So we were fortunate to receive some notoriety and some media attention not long after I launched the website. So patients increasingly contacted me asking me to help them find a reasonably priced robotic prostatectomy, a reasonably priced colon resection, a reasonably priced open heart surgery. I wasn't shy. I just picked up the phone and I called the surgeon and said, what is hospital you work at that's the least vicious that you think we can get some pricing out of? And they'd give me an answer. I say, how much do you want for a colon resection? Well, I don't know. Well, pick a number. Come on, let's put a price together. This patient's calling from Florida, and they want to travel to Oklahoma to get this done. If we can manage to put a deal together, broker, I mean, if you want to put a word on it.
Sure.
And so I would get a call from this hospital administrator. They'd say, well, what's going on? I said, well, this patient's got colon cancer, and they live in Florida, and they're ready to travel here. But you got to sharpen your pencil. I mean, if you come up with some really stupid price, you've kind of broken the kumbaya, and they're not coming. So I wound up getting great pricing from hospitals for this kind of stuff. I would throw in the surgeon fee. I'd call the anesthesiologist and talk them off a cliff because the anesthesiologists are the worst in coming up with a fee. They can do it for plastic surgeons, but for some reason, they can't think through, how am I going to price a 90-minute colon laparoscopic colectomy? So, yeah, I put all this stuff together and tell the Florida patient, here's the price. And so this clearinghouse that manages all this and collects the money and pays everyone is called Atlas Billing Company. And it has its own website separate from the surgery center. But there you'll see 360 fusions and pituitary tumor, removal. You see all kinds of inpatient stuff. And so I branched out into curating bundles. I think that and anesthesia are basically, those are the things that I do. And I'm staying out of the DPC world. Those guys know what they're doing.
Perfect. Yeah. Stay in your lane. I love it. We're wrapping up on our hour here. Dr. Smith, is there anything else that you kind of want the endovascular community to know about when it comes to these centers?
Yeah, I would encourage everyone to start with the default position that every single service that I provide can have a price attached. Now, you may come across some where you don't feel like that's true. Keep in mind, on Atlas Billing Company's website, I have maternity pricing. Now, I was told that can't be done, but it can be done because a lot of maternity is predictable. There's a part of it that's not, and that's why God made insurance. So I would encourage your guests to start as a default that every single thing that I do, every service that I perform can have a price attached. Maybe I just haven't figured it out yet. From there, I would start talking to the buyers. And the buyers is the self-funded world. A lot of the people that are in your audience play golf or go hunting, and they probably have friends that are at the country club who are the CEOs of self-funded companies. And so you can have these conversations. Do you realize if you're paying, $25,000 for what I do for $4,000, you're probably being ripped off. I can help you. And so you begin to have these conversations. So I would encourage your listening group to look at the Free Market Medical Association, consider joining so that you can network with self-funded buyers from all over the country who will waive the deductible and copay and pay all the travel costs for their employees to come see you. Assume you can do this. And my final advice is to acknowledge that the hardest thing about creating bundles and placing prices on our service is keeping it simple. It is very easy to overcomplicate this, and we're programmed to overcomplicate it. So just be sure that you keep it simple and don't let it get overcomplicated.
Excellent words to end this session. Dr. Smith, thank you so much for being on the show today.
You bet. Thanks for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at @_BackTable on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Aaron Fritz, and co-hosts
Chris Beck,
Sabine Dong,
Michael Barraza,
and Ali Behetti.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang,
Manisha Naganathanahali,
and Manbir Singh Sandhu.
Administrative support provided by Jamila Kennebrew.
Intro and extra music is Ripperoo by Skeptic Moon. Find us on Spotify or at local live music venues in New Orleans, Louisiana.
Thanks again for listening.